Hello and welcome to today's webinar sponsored by XL Catlin and the Sullivan Group. We are lucky to have Dr. Tom Syzek with us today, speaking on the opioid epidemic, from poppies to people. Thank you so much for joining us. Before we hand the ball over to Dr. Syzek, just a few housekeeping announcements for you. If you need any technical assistance, please go ahead and head over to the chat box and you can chat directly with the organizers. If you have any questions during the day, we'll also be watching them in the questions or the chat box. Feel free to enter them throughout today's presentation, and we'll have a Q&A session at the end to address those. If you have ideas or requests for future topics, we'd love to hear from you. This is my email address, jpichet@thesullivangroup.com. Feel free to send them my way, and maybe we can talk about them in the future. So without further ado, I'd like to introduce Dr. Tom Syzek. He's a veteran emergency medicine physician and VP of e-learning solutions with the Sullivan Group. Dr. Syzek, the floor is yours.
Thanks, Jenna, and welcome everyone, and thank you for joining us on this webinar. My goal today is to make the next hour worth your while as we discuss really one of the hottest topics of today, the opioid epidemic. Almost every day you can pick up the paper, as I did my own local paper this morning, and there's something about opioids or heroin, unfortunately. But our objectives today are to explain just what is this opioid epidemic, what are we talking about, and also briefly tell you about alternatives to opioid use in clinical practice. Now, don't cringe. I realize most of you listening are not clinicians, and so I won't get too much in depth about the clinical practice part. But I will also outline strategies to reduce harm from opioid prescribing and abuse. So what are some of the strategies from the healthcare side of the problem that we can do? I'll also talk about the liability associated with opioid prescribing. So first, the headlines. As I mentioned, any day you pick up the paper, you're going to find something about heroin or opioids. So the opioid epidemic and crisis have really dominated the headlines for at least a year around the country as the public, the press and the government agencies are finally catching up to what is happening in the homes and the emergency rooms across the country. These are just a couple sample headlines from the CDC. The first one is obvious, that opioids can be addicting and cause overdose and death, and that money is being spent to help states fight the opioid overdose epidemic. I think the figure of 28.6 million will end up being some power of 100 too small, but certainly need to start somewhere. So again, here's another headline from just last month when President Trump's recognition of the opioid crisis was put in their press release. So it's really just too early to tell what this type of announcement will mean in terms of real action or solution to the crisis. So those are headlines and millions more, but with those headlines out of the way, why don't we step back and just cover a few basics. I'll start by defining what an opioid is. Opioids are a class of drugs that include both natural and synthetic drugs. Natural opioids are the ones we know, like codeine, morphine, and heroin, and they're called natural because they are derived from the poppy plant, or parts of the poppy plant, or concentrated from the poppy plant. The other classes of opioids are either semi-synthetic or completely synthetic. Completely synthetic opioids are ones such as fentanyl, sufentanil, and carfentanil. Don't worry, no quiz at the end, although carfentanil will come up again in a later story. So how do opioids work? What are they used for? They act on the nerve cells in the brain and nervous system to relieve pain. That's their main benefit. But as a side effect, and this is probably where the trouble is, they produce pleasurable effects such as euphoria. The origin of the opioid crisis really goes back, back to the origin of opium hundreds of years ago, but recently, back about 40 years, when two publications suggested that high-dose opioids could be used to treat chronic pain without any risk of addiction. Wow, great news, fountain of youth or something for pain. So the first publication was a letter to the editor published in the New England Journal in 1980, and this letter stated that less than 1% of patients receiving narcotics while they were hospitalized became addicted. So they were touting the low addiction potential. Well, this was followed by a study in 1986 suggesting that chronic pain could be managed with opioids without risk of addiction. This was kind of the landmark study, which has been poo-pooed quite a bit since. So soon after that, going down the timeline, drug companies marketed opioids to physicians for long-term non-cancer pain. It's understood that cancer pain, may take huge amounts of frequency and amounts of opioid medication, but we're talking about non-cancer pain here. So later, after drug companies marketed these opioids, the FDA, Justice Department, and Senate, all three investigated these controversial marketing tactics and financial relationships. And this actually resulted, as some of you remember, in 3 top drug company executives pleading guilty to criminal charges of misleading clinicians, patients, and the FDA about the risks of OxyContin in particular. So now we've got this stew brewing here with low addiction potential being touted, the drug companies marketing these drugs. So in the midst of all this, along comes the focus on pain as a crisis in itself, pain crisis, demanding our attention and relief. And this continued with the Joint Commission labeling pain as the 5th vital sign in 2001, giving an equal importance to your pulse and temperature or respirations and blood pressure. Then the Institute of Medicine, 10 years later, in 2011, talked about relieving pain should be a national priority. So the pressure now is on the prescribing healthcare practitioners and hospitals and healthcare institutions to pay attention to pain and relieve it. They're not all saying you have to give them opioids, but certainly this fed some of that concern. So to this toxic brew of policy and profit, mix in the pressure of patient satisfaction surveys on physicians to control pain. I can tell you from my experience, when you're measured on patient satisfaction, and even if your contract, say as an emergency physician, is dependent on patient satisfaction, and you're constantly showed this, this is an additional pressure to meet patients' needs, particularly with pain, and sometimes this would spill over into saying, honestly, gosh, it's just easier to write a prescription than it is to talk to this patient about why they shouldn't have it. So where did this timeline lead us up to this point? Consider the current magnitude of the opioid crisis. In 2011, there were more than 420,000 ER visits related to narcotic misuse or abuse. The very next year, there were 259 million opioid prescriptions. Mind you, this is not number of pills, this is a number of prescriptions written. That's enough for every single person in the US, almost. So by 2013, the number of people who either abused or were dependent on opioids was 1.9 million. And this is where we're hovering now, somewhere in the 2 to 2.5 million range of people in the US who are dependent or abusing opioids. So all this is during a time when you look at other healthcare crises, heart disease and cancer death rates are going down. The entire medical community is driving these rates down with cures for cancer and prevention of heart disease, while the death rates from opioids are going up. So if this doesn't define a public health crisis or epidemic, I don't know what would, and thus the definition of the opioid epidemic. So here's a color graphic, breaking up all the text there with a color graphic showing the number of painkiller prescriptions per 100 people back in 2012. So the darker the color, the highest rates of prescription. So you can see the epicenters are this Appalachian belt from Mississippi up through Tennessee, Kentucky, Ohio, West Virginia, now further up into that area over the past few years. So these epicenters are in the Midwest, Southeast, including Ohio, where I practice. In fact, I see on the news that Montgomery County, which is the Dayton, Ohio area and surrounding, is the epicenter for the crossroads for the heroin trade because of the interstates, because of the socioeconomics of the area, and Ohio is always in the top 1 or 2 with the number of opioid overdose deaths. So back when I was there, just a few years ago, it was apparent to any ER physician in that area that trouble was arising in a big way. We started to see dozens more drug-seeking behaviors in the ER every day, and more overdose deaths from pills and heroin. So how do we get from acute pain, just a prescription for pain, to chronic use? The duration of prescriptions matter. This is an interesting study. It showed that for those patients just receiving a one-day opioid supply, one day acute pain, broken finger, sprained knee, whatever it is, 6% of those patients will still be using narcotics in 1 year. Now, give the same group of patients a greater than 1 week opioid supply, right? So we're going to give them a week now. Almost 3 times as many are drug dependent in a year. So this study is a good background to show concern about strategies to limit the spread of opioid use and abuse by perhaps changing prescribing habits. Abuse and misuse of opioids can be deadly, so now we're switching from prescription to what happens in the overdose arena, as this slide clearly shows. Drug overdose is now the leading cause of accidental death in the US. Now this includes all drugs, so drug overdose on any drug, and not just opioids. However, opioid overdose deaths make up the majority of that. They've quadrupled since 1999, and now it's estimated 33,000 deaths just as of 2 years ago. Consider this. In the 14-year period from Y2K, 2000 to 2014 now, 500,000 Americans have died from opioid overdose. And estimates vary all the way up to 78 opioid overdose deaths every day. It's kind of a tongue twister. I was better off when they just called it narcotics, so I could pronounce it better. The states with the highest overdose death rates are mostly the same states with the highest opioid prescription rates. As we mentioned, that Appalachian belt, West Virginia, Kentucky, Ohio, but now up into New Hampshire, which is getting some notoriety as well. The deaths from overdose are now increasing mostly in the Northeast and in the South. So here's a graphic similar to the previous one, but what this is showing is the overdose death rates. The darker the state, the higher the death rate. And again, look at that southern, upper Midwest and Appalachian belt from Tennessee, Kentucky, Ohio. I can't really explain Utah or New Mexico, but these are the facts put out by the CDC as far as the rates of drug overdose deaths as of 2 years ago. So within the past 10 years, healthcare professionals and agencies recognized the epidemic of opioid pill misuse and abuse. Efforts began to address overprescribing by clinicians, and they shut down the pill mills. Tens of thousands of people now who started by abusing narcotic pills by prescription or by diversion or obtaining these pills from friends, family, or buying them, the FBI and the DEA cracked down like crazy, and now they're cut off from access. Only problem is they're still addicted. So this was the genesis of the recent rise in heroin use. Heroin is simply cheaper and easier to get. Consider it's $8 to $10 for a dose compared to $80 for one OxyContin pill. So heroin use went up 37% every year since 2010. Well, what relationship does heroin have to other drugs? It's certainly linked to other drugs, as shown by this graphic. Most heroin users use at least one other drug, and most use 3 other drugs. So there's multiple drug interaction and addiction here. It's also interesting to see here that addiction to alcohol, marijuana, cocaine, and opioid painkillers are all more likely to be addicted to heroin. Of course, the far right in the red, if you're addicted to opioid painkillers, you're much more likely to switch right over to heroin. But it's also true for the other drugs. Interesting kind of background. So this is a story about Cincinnati, where I practiced. I was gone by this day in August 1 year ago, so just about a year ago today. So over a 6-year period, this is an NPR story, over a 6-day period, 6 days in Cincinnati, including a weekend, there were 174 overdoses leading to ER visits. This was due, as most of you know, to a synthetic opioid, carfentanil, which was used by the dealers to cut and mix into the supposed heroin. Why? Because it was cheap. There's no human use for carfentanil. It's used to tranquilize large animals, including elephants. So it got the moniker of elephant tranquilizer. Well, the problem is with carfentanil, it is 100 times stronger than fentanyl. And if you can imagine, it is 10,000 times stronger than morphine. So you go to shoot up your usual dose from your usual dealer, thinking all is well, I'm just going to get my high. But you have just injected something that's 100 to 1,000 times stronger than what you're normally used to. The city just about ran out of Narcan. The EMS was overwhelmed, and they knew, and the nation knew then, that we were in huge trouble, worse than we ever imagined, starting with that weekend. So the bigger picture, interestingly, is that the opioid epidemic is costing American society an estimated $78 billion a year from a study in 2013. Now, this figure includes healthcare costs, which is a lot of it, but also lost productivity and costs to the criminal justice system, where there's drugs, there's crime and robbery, of course. Now, substance abuse as a whole, including tobacco, alcohol, and illicit drugs, costs 10 times that much, $740 billion. So opioids is maybe a tenth of that. And interestingly, the opioid crisis affects the job economy as well. These are some recent reports that heroin users obviously nod or fall off at work more often. And even those workers whose family members are addicted, they need more time off to go deal with opioid-related family emergencies. Spouses, sons, daughters, brothers and sisters, and kids. Opioid users are less productive. They miss twice as many days off work as workers addicted to other drugs. And as far as the job economy, this interesting statistic that half of unemployed men in their prime age, their working age, take medication for pain every day. So you take half of the unemployed men, they're taking pain meds. They're less likely to even seek jobs or be able to pass drug tests. So this has a huge economic effect across the country. Well, the opioid epidemic affects all ages and walks of life, tragically. 122,000 addicted adolescents, these are teenagers, 12 to 17 years old, were addicted, so over 100,000. And 21,000 of these used heroin in the past year, the year before 2015. More interestingly, most pills were obtained and given free by a friend or relative. They're just out there in prescriptions, floating around, and either for fun or for profit, distributed or stolen from friends or relatives. The rates of prescription opioids to this age group, who knows why, but it doubled from 1994 to 2007. The impact of opioids on women are that women are particularly impacted by opioids. They're more likely than men this was interesting to me, they're more likely than men to have chronic pain and get prescription opioids in higher doses and use the drugs longer than men. So the increase in overdose deaths are affecting women far more than men, with the death rate up 400%, as almost twice as high a rate as men. And the overdose deaths are tripled just in the last few years. What about communities? What are the characteristics, say, of a community, if you could profile a community with high opioid prescribing? So counties and towns with higher opioid prescribing and abuse really have these characteristics. They're small cities or towns. So now, we're getting kind of a profile of this Appalachian belt and Midwest. More residents who are Caucasian and more uninsured and unemployed people. This is really, in the best part of the best-selling book, The Hillbilly Elegy, that it was centered in the Middletown, Hamilton, Dayton, Ohio area as an epicenter of this opioid abuse, which is infused into that best-selling book as a big problem with that type of population. All right, here's the big one. The amount of opioids prescribed, in 2015, talk about epidemic. It was enough to medicate every person in America around the clock, 24/7, for 3 weeks. I'd say we need to really consider changes in the way we approach opioid prescribing. So one study of overdose deaths in one community, San Diego, revealed some really interesting findings and red flags. So what they did is, in a 12-month study, 254 drug overdoses in San Diego, not just opioids. What they did is, now they call this diaries because the patients did not keep diaries, but they labeled it diaries because when you investigated the prescription drug monitoring program of the state for these patients, these reports were like diaries. They showed the story of why there were overdoses and what happened. And these prescription drug monitoring program records showed that many of these who overdosed, there were problems. It was right in the record that they were prescribed drugs by multiple clinicians. There were potentially dangerous drug interactions on record that were ignored. There were escalating dosages. The next prescription was more and higher, and so on. And there was evidence of doctor shopping. So obviously the PDMP wasn't used greatly to help deter this type of problem then, but this gained some notoriety as a way to find out kind of what the pattern was in these drug overdose deaths. So what did they find out in this study? This study of San Diego overdoses showed that over half of the prescribers, so who's prescribing the medications? Just statistically, okay, not trying to lay blame here, but most of the prescribers were primary care, half, followed by emergency physicians, psychiatrists, surgeons, yes, even dentists who can prescribe narcotics. And interestingly, but not surprising to me, pain specialists are on the bottom of the list. Why? Because they have contracts with the patients. They do drug testing. They're professionals at this. So the pain specialty itself, if patients can get to it, probably does the best job at controlling and monitoring prescriptions. The study also showed that the number of pills, who prescribed the most pills per prescription. And what this shows is the average number of pills per prescription. So if you write one prescription, what's your average number of pills in each one? By medical specialty. Well, surgeons lead the pack, orthopedic and all surgeons. So there are several studies show that opioid pain medication is really overprescribed after a surgical procedure. Who knows why? Just to make sure, sure, surgery is painful and you want your patient to have relief, but I think, and enough pain medication to relieve themselves of pain. But I think that perhaps this is showing this is overdone, and this provides an opportunity for improvement using available guidelines. I'm pretty sure that some of the surgical societies now have addressed this or will be addressing this soon, just in guidelines and evidence base and best practices. So I think we'd all agree at this juncture that all the data regarding opioid misuse, abuse, and overdose is interesting, but it's also very alarming and really quite depressing. You know, when I was in the middle of an emergency department in the Cincinnati area, and EMS brings in somebody unconscious, barely breathing, and you find out it's a college grad who works in the nearby mall, you know, raised by a good family, whatever, and only to find that they have been on Percocet and then switched to heroin and overdosed to the point we couldn't resuscitate him. It really became a very challenging and depressing type of place to work. I mean, we had basically heroin overdose come in every ER, every day, and some places many, many times a day. EMS is getting so good at this, like they know more about overdoses and Narcan than all of us put together. So enough of that. We'll switch gears a bit here to look at the trends in liability of opioid prescribing. So first, there's potential civil liability, which can result and does result in fines and judgments. The risks include liability for overprescribing opioids in quantity and frequency over long periods. This is the classic description of a pill mill, basically a physician or practitioner who sets up shop, basically has a line out the door. You come in, you know, you say, you know, may not have to say anything, but if you say, I've got pain, this or that, and they have pre-printed prescription pads, and these prescriptions fly out the door for $100 a visit, that's a classic pill mill, and that is not an exaggeration of what was occurring in southern Ohio and the surrounding states of Kentucky and West Virginia. The other liabilities include failure to maintain accurate records. So certainly medical boards and states have their laws on how to maintain patient records. Or failure to limit opioid prescriptions for individuals you know are addicted. So these are some of the potential civil liabilities. And here's a case. So take the case in 2010 of Dr. Conti in Texas, who was found to be negligent in a malpractice death of a man because he prescribed a combination of Vicodin, that's a narcotic, Soma, muscle relaxant, and Xanax, all of which are sedating and depress the central nervous system. And the judgment was $1.7 million in compensatory damages and $8 million in punitive damages. So, gosh, you know, should we be alarmed? They're just singling out this one doctor. Well, he was associated with 17 clinics, most of which he never went to. He had pre-printed prescription pads with narcotics on them that could be handed out or sold. And he provided more than 15,000 prescriptions. So that was just the civil liability example. So there's other potential civil liabilities, such as contributing to a patient's opioid addiction. I don't know a great detail about it, but I read a little about the 2015 case in which the West Virginia Supreme Court ruled that they allowed addicted patients to sue doctors and pharmacies for getting them addicted, prescribing in the amounts that got them addicted. This is under the legal doctrine of comparative negligence. Yes, the patient was certainly negligent because they took the meds, but there's also negligence on the part of the physician for prescribing outside the norm that physicians should be doing. Physicians may also be liable, and their licenses, sure, as well, if they fail to check these prescription drug monitoring program databases per the regulation of their license and the laws of their state. So I just checked on Ohio, and not only do you have to check in certain circumstances of prescribing narcotics, not only do you have to check the PDMP for Ohio on a patient who you are seeing, but if you're on a border of Ohio, like on the border of Kentucky or Indiana, you have to check the bordering state's PDMP. So this creates an additional burden on the prescribers and providers, but there are sanctions and problems if you do not comply with these regulations. The liability on the bottom bullet also includes discipline by the state medical board that oversees and disciplines physicians, and they identify outlier prescribing practices. Well, it may be a rare event when a practitioner can face criminal prosecution for violating the Controlled Substance Act by knowingly and intentionally prescribing outside the usual course of medical practice. This is a federal law, Controlled Substance Act, or a state equivalent. So you're going to prescribe outside the usual course of medical practice or for non-legitimate medical purposes. So the DEA is busy here. In the 3 years from 2011 to 2014, adverse DEA actions quadrupled from 88 to 371 cases. These are reported in the National Practitioner Data Bank. A physician may actually face charges of homicide or manslaughter. This is not happening every day, but there is this notorious case of Dr. Singh in California. And she was convicted of second-degree murder of a patient who died of an overdose on Xanax and oxycodone prescribed by her. This was the first opioid murder conviction in the U.S. Very high profile in California, very controversial. But again, she basically had a pill mill type of practice, and the jury and prosecutors in the state obviously felt that this amounted to second-degree murder, and she is still under conviction from that. So what about, let's turn to another kind of liability, it's civil liability and malpractice claims. What about opioid-related malpractice claims? A claims analysis by the doctor's company over an 8-year period showed that about 15% of claims related to medication involved narcotics. So there were lots of medication-related claims, 15% are narcotics. And where do they come from? Most of these come from the outpatient setting, physician offices and clinics, ambulatory and day surgery centers. Happy and proud to say that only a few percent came from the emergency department, which always seems to get the blame for a lot of things, and 3% at home. Most of the allegations in these opioid-related claims were of improper medication management or treatment. So this can really indicate, what's the problem here? It may indicate a lack of education or failure to follow evidence-based guidelines. You know, you're using the wrong medication for the wrong thing, too much, wrong dose, as shown here too. So that's certainly an opportunity for education. But as far as mistakes go, wrong medication or just a plain wrong dose, that's really a minority of claims. And interestingly, I think the majority provide an opportunity to intervene and have education and guidelines to turn around these claims of improper medication management and treatment. So this is kind of an obvious slide here, but the data from the claims analysis just shows the type of pills that were involved, the type of medications that were involved in these claims. Pills are more implicated in the outpatient setting, say methadone pills, 16% of outpatient claims versus 4% inpatient. Same with OxyContin, which is a pill. And turn it around, the injectables are more commonly implicated in the inpatient claims, as you see Dilaudid, morphine, and fentanyl. Now these come in other forms too, but they have an injectable form that's used very commonly in the hospital. So what about the top diagnoses? You know, so you see a patient, they end up having a claim. What was their medical diagnosis when they're involved in an opioid-related claim? In these outpatient claims, patients are coming in for and then filing malpractice claims with pain in non-specified location, followed by spine-related pain. This is the back and neck pain, the notorious, low back and neck pain problem. Pain in the joints and extremities, and issues with mental health and drug dependence. It's again interesting, but maybe logical. The severity of the patient injury was a lot higher in these outpatient claims compared to inpatient claims. So my guess, which may be wrong, but my guess is that the inpatient mishaps are more likely to be in patients who are, they're in the hospital, they're being monitored, And if there's a mishap, there was more likely to be rapid intervention, and the outcome wasn't quite as bad. But that's just my guess. Turning now, what about the inpatient claims? This is a classic scenario. The inpatient claims mostly occurred in a patient's hospital room, where they were transferred from PACU, which is post-anesthesia care unit, the recovery room, or ICU, in a highly monitored situation. So here's the scenario. A patient is in the ICU or recovery room. They're highly monitored. They're receiving IV opioids. And then it's time to go. They're transferred to a general medical surgical floor. Well, the staffing ratio is less. There's less intense monitoring, say by cardiac monitoring and oximetry monitoring, and they suffer an adverse event related to continued opioid administration. So that transition from closely monitored intensive care type unit to the floor, again, represents an opportunity for some type of tool to be invented or used to cut down on these adverse events within the hospital. Okay, well, turning to strategies. I certainly don't have the pretend to have the answer to how to eliminate the opioid epidemic. There's certainly legislative, regulatory, policy issues that are far greater than any one of us. But what can the medical community do? So this was the call to action by the AMA president, Stephen Stack, who also happens to be an emergency physician. So he recognized we are on the front lines of an opioid epidemic, crippling communities across the country. We must accept and embrace our professional responsibility to treat our patients' pain without worsening the current crisis. These are actions we must take as physicians individually and collectively to do our part to end this epidemic. So A, it definitely labels this as an epidemic and says we've got to do something. So most of the participants on this webinar are not clinical, so I won't devote a lot of time, in fact, just this one slide, to the issues of what alternatives can we use in pain relief to opioid administration. So Alternatives to Opioids now has its own acronym. You can take this away and sound cool now by talking about ALTO, Alternatives to Opioids. The practice settings I'm talking about here mainly are the ER, but also any practice setting that's treating acute pain. So the key principles of ALTO are perhaps obvious, but is to use opioids as infrequently as possible, only as second line, and only after using other alternatives or exploring other alternative treatments. So here's some examples, just so you can kind of understand where this is going. So for kidney stone pain, which is really one of the worst pains you can really imagine in the emergency department or anywhere, is instead of using narcotics, use intravenous lidocaine. This is what you numb up or anesthetize wounds when you suture them. Well, it also gets in the vasculature, blood vessels, and down into the ureter and helps numb that area, and it's effective for renal colic. There's other medicines, non-narcotic, for that too. What about for low back pain? A big one. Studies are showing that narcotics really don't do anything in the long run to help low back pain. So why not use non-steroidals, anti-inflammatory? This is ibuprofen. Topical patches like the ones advertised by Shaq on TV, and trigger point injections, not IV injections, but trigger point injections. Makes it, this statement about low back pain takes me back to 20 years ago when my medical director in the emergency department in Cincinnati, somewhat callously, I thought, and cruelly, refused to give anybody narcotic prescription unless they had a major broken bone. Nobody. He just had a rule, and he would use this magic drug he called ibuprofen, which is just a tricky pronunciation of ibuprofen, of course. But I thought it was unreasonable at the time, 20 years ago in the 90s. But now I look back and I think that one doc predicted and knew what was coming. He may have been cruel anyway, but I think he had it right on when it came to that. Other examples are ultrasound-guided nerve blocks or extremity fractures. So if you break your arm or leg, don't go right to the central nervous system acting opioids, but why not use modern technology and training to use an ultrasound on the arm or leg to find right where the fracture site is or the nerves and block these nerves and achieve total pain relief, at least for some time and maybe for several days. And lastly, acute headaches, of which 5% of ER visits in the country are coming in for headache. Why not use non-opioid meds that certainly work? So there's millions of ED visits for these conditions every year. It's a great opportunity to turn the tide of the opioid epidemic. As a concrete example, this year for the first time at ACEP, American College of Emergency Physicians meeting in October in DC, there are going to be hands-on demonstrations and learning stations on how to do alto examples. So there's other resources and guidelines that can be used. This is in 2016, the CDC came out with their prescribing guidelines for chronic pain. So this is chronic non-cancer pain. This is really aimed at the primary care physicians who prescribe opioids for chronic pain. And so this is really not applicable to urgent care, post-op, or emergency department. So the point is to use these guidelines to select the dosages, the duration, follow-up, and discontinuation of opioids. And also to assess the risk of each patient. Who's likely, what risk factors are present that this patient then could get in trouble or is likely to get addicted? There is a checklist that can be used. And addressing the harms of opioid use. So this is informed discharge instructions for these patients. So I mentioned a few slides back, and I probably should have put this earlier about, well, in case you're confused, what are PDMPs, or prescription drug monitoring programs? So I thought I would go back and define these programs and their role in the opioid epidemic. So a PDMP is a statewide electronic database. That's all it is. And it collects, maintains, and disseminates information about controlled substances, okay? So when a practitioner prescribes medication, they do not enter the data. The pharmacies provide the data to the PDMP in their state. It has grown, PDMPs have grown to be in all 49 states. And unless I'm mistaken, yesterday I looked up and I said, what one state isn't involved? And again, I could be wrong, but according to yesterday when I looked it up, it was Missouri for reasons of privacy issues. So here's how this works. Basically, a prescriber, a physician, PA or NP, is treating a patient, and they think they may need to prescribe opioid medication or a controlled substance. They can go right online on their computer, in their office, in the ED, and access this online database by name to find out if their patient has received any prior controlled substances. How many, what, from which physician, what pharmacy, and all that data. Now, it doesn't say, oh, if your patient is in this database, don't give them any. There's a lot of judgment and guidelines that have to go into how you interpret the data that's there. So on the bottom bullets here, it describes the benefits or potential benefits of the PDMP. These are statewide initiatives, and the DEA is not involved in these. So it's just to support legitimate medical use, okay? So you look it up and you say, gosh, this person's not a user, abuser, I don't see any previous history. That's going to support access to legitimate prescription use. However, I think what we're getting into here is identifying and deterring or preventing drug abuse and diversion. Also, to intervene in patients who are receiving way more prescriptions than they should, who are obviously now addicted, and to intervene and potentially counsel and refer those patients. It's also used for megadata, outline use and abuse trends. Where do you think a lot of that data from the previous graphics came from? And also to educate everyone around the country, legislators, the public, and practitioners about abuse, diversion, and addiction. So yet another partial solution to the opioid epidemic was suggested by this FDA panel that called for mandatory training in the use of opioids by doctors. And to that I say, make it great training, and I say, why not? It's an epidemic. We can use all the data and information we can get. So strategies to combat the opioid epidemic, they need to be specific for each specialty, because we're not all the same. You know, we have different circumstances. Our patients are not all the same, and the locations are not the same. The CDC guideline mantra for non-cancer chronic pain is start low doses and go slow. For acute pain, we've talked about this a little, consider the alternatives, limit the quantities, limit the refills, educate the patient on risks and benefits and the potential addiction warnings. Communicate back. Say if you're in an episodic care center, emergency department, urgent care, freestanding ED, elsewhere, communicate with the primary care physician so everybody's on the same page about who's getting what. Access the risk factors for unsafe use. So talk about, that should be assessed, not access. Risk factors for unsafe use. Talk to the patient and perhaps do a questionnaire, if you can, about what other medications they're taking that may lead to bad outcomes and overdoses. And lastly, of course, access the PDMP before prescribing. You may be required to do this in certain circumstances. So here's a publication that just came out this year by one of our emergency department partners, the Colorado ACEP, and whose current president actually is one of our collaborative members in the Sullivan Group. This is an excellent resource for physicians in emergency medicine and any other specialty. It goes over a lot of the things I just went over. How did we get here? What are the current challenges? And in detail about alternatives to opioids, how to treat patients, what to say to patients, where to refer patients. This directly addresses the opioid epidemic. And if you're going to get one resource so far for prescribing for acute pain, this is free and available online as a resource, and I highly recommend it. A lot of work went into it, and I found it was stunningly excellent in bringing everyone up to date. So I won't go through it page by page, but here's some recommendations, for instance, that come out of it. We've talked about some. I won't go in detail, but these are some of like the 10 commandments of using opioids or appropriately using opioids to avoid worsening of the epidemic. And here's some more recommendations. Like I said, I won't go through them, but they're there in that publication. So in order to positively impact, we're just about to wrap up here, in order to positively impact the opioid epidemic, healthcare providers will require not only more education, but also a change in attitude to a non-punitive approach to what is now referred to as PWIDs, people who inject drugs. So now you know two acronyms, ALTO, alternatives to opioids, and PWIDs, people who inject drugs. So this is hard to do, okay, because patients come in, they can be very manipulative, they are desperate, they're addicted, and the only thing on their mind is they've got to get a fix. They've got to get a prescription from you. They've got to do something. So it's very difficult not to be judgmental in any setting with these patients. But this is basically the Mother Teresa approach. We have to manage these patients without judgment. Mother Teresa references that she didn't question why people came to her hungry. Why are you hungry? She just fed them, okay? So I'm not saying feed them with narcotics. I'm saying use empathy and meet patients where they are. I think in the long run, as difficult as this is really the only way to impact patients in the acute setting. We need to educate ourselves as practitioners and have ability to counsel patients to reduce the dangers of overdose, infection, and complications. As an example, if you don't, say if you put your head in the sand and say this isn't happening in our community, we're not going to address it, we're going to blame the users. There's this famous case in Austin, Indiana, not of opioid epidemic, but of HIV epidemic, where 190 cases spread like wildfire in a tiny community because of lack of recognition and because of judgment and lack of access in that community. So what can we do? We can refer PWIDs, people who inject drugs, to syringe access programs. This is, politically highly controversial, but It is supported by the AMA when combined with addiction counseling, and give or prescribe Narcan at discharge as one of the key points that you've heard about. So as an example, this is a handout for patients. Some programs even go so far as to advocate teaching the patient how to safely inject themselves in order to avoid infections, blood clots, and organ damage. This would have been considered heresy or malpractice to educate a patient on how to illegally inject themselves at home. But now, I mean, the thinking here is in the short term, in an emergency department, in an acute care setting. We're not going to stop IV drug abuse on that episode, but we can sure help prevent the complications such as hepatitis, MRSA, the spread of HIV, vascular complications. And so this is a change from when I started practice, or even a few years ago, to basically giving patients all the information that you can to keep them safe while addressing the longer term rehab, detoxification, policy, and regulatory mechanisms. So in the end, this is a kind of a last slide. I was asked the question, what can hospitals and healthcare facilities do to educate, monitor quality initiatives and improve practices related to opioid safety? What tools can you use? So here's a takeaway for you. You can modify, use, abuse, throw out any way you want this survey, a sample survey I put together. It's kind of a questionnaire to assess yourself as a hospital, to fashion your own self-assessment and monitoring program, so that together we can positively impact the opioid epidemic. That's indeed a threat to our patients, a challenge to all of us as healthcare professionals, and it's a crisis of major proportion to the entire country. So with that, I will turn it back over to Jenna. Thank you so much for your time and attention. I'll be open for any questions and happy to answer any. And again, thank you for joining, and back to you, Jenna.
Great, thank you, Dr. Syzek. Great information, very informative, and we appreciate the strategies that you've provided as well to reduce patient harm. I do have a few questions here. Please keep in mind that the question and chat box are both open, so before we start, if you have a question, please feel free to enter them there. Dr. Syzek, the first question for you relates to your experience. Have you run across any opioid malpractice claims in your experience, either from when you were in the risk department or as an emergency physician?
Thanks, Jenna. So I would say, in the 90s, 2000s, until 2010, no. I mean, unless it was criminal. So no, they really hadn't hit the radar as far as malpractice actions that we experienced. Then we began to see this a little bit. And one case we did have was actually we were doing some prison medicine, actually jail medicine, where a patient entered the jail, as many jail inmates do, and he had a drug problem. He was a heroin addict, and we employed the nurse there. And upon going through withdrawal, the allegation is that we did not properly assess and monitor that patient. So that was an allegation. It was certainly brought against us as the medical provider, but also against the sheriff, the facility, and so on. And frankly, in that case, it was judged that there was negligence in assessing and monitoring that patient, who died of complications of heroin withdrawal. It's always said you don't die of it, but when you get electrolyte disturbances or dehydration from withdrawal, yes, you could. So now, on the other hand, I think we are going to see, as we saw in that West Virginia case, liability and malpractice actions for overprescribing, leading to either overdose and or addiction. I think we're on the cusp of that, and my prediction is we will begin to see somewhat of a more cottage industry taking up within the malpractice industry that will address opioids specifically. But in our experience, it was just beginning to start when I left Ohio.
Tom, here's a question from someone. Lidocaine for renal colic, is this licensed use? What are the risks of cardiac arrhythmias with that? Also, what can pharmacies do?
So great. Lidocaine, yeah, lidocaine for renal colic. So we're talking the use of lidocaine when you have a patient come to with bad kidney stone pain. So lidocaine is not a controlled substance, okay? But obviously a licensed practitioner. It's not by pill, it's by injectable form, so it's going to be used in acute care settings. And again, it's the exact same drug that's used to numb lacerations before stitching. So it's not controlled substance. Yes, as with every drug, it can have its dangers and side effects. And so the side effects are dose related. You put, if you inadvertently administer way too much lidocaine intravenously, not only will their renal colic be relieved, but they can have a seizure. So yeah, intimate knowledge of pharmacology is critical as you explore these alternatives. Pharmacies, I think, in my experience, in answer to that part, I think are doing a great job. They're the ones who are sending the information to the PDMPs. And often when I prescribe medications, and pharmacies would call me back and say, did you know they just received this other medication? Or did you know there was this interaction? Or did you really mean to do this? They're extremely knowledgeable and helpful, and I welcomed any call back from the pharmacy that questioned, was this really in the best interest of the patient? So I think pharmacies are doing a good job just by doing exactly what they do, and that's populating the prescription drug monitoring programs and accessing those when they dispense medication.
Great, thank you, Tom. And there was a question about the availability of this. So this will be, it is recorded and it will be available 5 business days after this recording. We could PDF that document that Dr. Syzek had presented as well. I presume that's what Shirlane was inquiring about. And then Luis asked the question, is the worst of the epidemic behind us?
You know, so I'm probably the wrong person to ask, but I will give an opinion because by the time you ask me what's a good stock pick, it's too late. You know, the wave's already passed. But I think the recognition is now peaking. Okay, these statistics I just talked about are easily available. We're having headlines now. The media, the press is picking this up. So the awareness is peaking, but the solution is not. There's very few things as powerful as an opioid addiction. Okay, so there is no immediate answer to transfer patients right off of opioid addiction onto something else. So no, I personally think that the awareness is now finally getting to where it should be, but that the overdose deaths, a number of addicted individuals, is not peaked yet. That's my feeling and prediction, just personally. And unfortunately, I hope I am wrong. Hope I'm wrong.
Yeah. And then we'll do the last slide, or the last question, I'm sorry. Alto, what do you think of ketamine for pain management in the ED, Tom? And that's from Mary Cusin.
Great. Somebody out there is on the cutting edge. And ketamine is now being researched, and evidence is coming out that there is use for ketamine for pain relief in the emergency department. So I think following guidelines, knowing that drug, knowing the risk, benefits, and alternatives, we are seeing cutting-edge emergency departments safely use ketamine for a variety of conditions, including dislocations, fractures, and so on. But be educated. You know, go to one of the ACEP talks on that and know what you're doing first, because there are potential hazards as well.
Great. Thank you, Tom.
With that, we'll wrap up today's webinar. Again, thank you so much for logging in today. We appreciate your involvement. And as mentioned prior, A video archive of today's webinars will be made available within 5 business days. So thank you, Dr. Syzek, for sharing this information today, and everyone have a great afternoon.
Thank you, everyone. Appreciate your attendance.